thank you very much for, first of all, for inviting me here, but second, for that very kind introduction. I feel as if there's no way that I'll be able to live up to that introduction, but I'll do my best. So today's talk is entitled, What are the Boundaries of Addiction? And as with all of my talks these days, I have a series of disclosures with respect to relationships with pharmaceutical companies, with the gambling industry, as well as legal consulting. So with that out of the way, I would like to focus on the clinical aspects and the science of addiction. And for me, it is helpful to think about this from a historical perspective. And if we think about the term addiction and how it's changed over time, I think that can be insightful. So the word addiction is derived from a Latin word meaning bound to or enslaved by. And in its original formulation, it was not linked to substance use or substance use behaviors. However, over time, going back several hundred years ago, it first became linked to excessive patterns of alcohol use, and then later to excessive patterns of drug use, such that by the time individuals on the experts in the field in addictions and substance use disorders were contemplating in the 1980s the revision to substance use disorders criteria for DSM-3R, there was, by accounts, uniform agreement that addiction meant compulsive drug use. However, I think that over the past 10 to 15 years, that notion has been challenged somewhat, and people have been thinking about whether addiction might apply to a broader range of behaviors outside of substance use behaviors. So in the 1990s, Howard Schaefer and others proposed several core elements of addiction, such as continued behavior despite adverse consequences, diminished or lost control, or a compulsive engagement in behavior, and a craving or an appetitive urge state immediately prior to the engagement in the behavior. And if we think of these as the core elements of addiction, perhaps addiction could encompass non-substance use behaviors. Another way of thinking about addiction that I think has gained popularity over the past decade is to think of addiction as a disorder of misdirected motivation, or as motivation gone awry. And by this, I mean that priority is given to specific motivated behaviors, particularly those that have immediate short-term rewards like drug use. And less priority is given to other motivated behaviors such as occupational or familial functioning or familial activities that may be associated with delayed gratification or delayed reward. So from this perspective, understanding motivated behaviors and the biology and the neurobiology underlying motivated behaviors might help us understand addictions and develop more effective prevention and treatment strategies. So some of the changes that have occurred over the last decade, I think, are reflected in the literature. And two articles that I would point to are ones that Constance Holden authored for Science, the journal Science, one in 2001 and one in 2010. The one in 2001 was titled Behavioral Addictions, Do They Exist? And focused on the question of whether by using brain imaging techniques, one could look for whether non-drug behaviors like gambling, exercising, overeating might share biological similarities with substance use disorders like alcoholism or drug addiction. In 2010, the article that she authored was entitled Behavioral Addictions Debut in Proposed DSM-5. And this reflects the proposal by the Substance Use Disorder Work Group Committee to move pathological gambling together with substance use disorders like substance abuse and substance dependence into a category of addictions and related disorders. And that work was in part driven by not only clinical and phenomenological similarities between the disorders, but also biological, neurobiological similarities, and some of that work I'll be discussing later today. However, if pathological gambling is going to be moved in the DSM from its current home to one with substance use disorders, that means that it's not currently categorized with substance use disorders, raising the question, what is its current home? And it currently resides in a category called impulse control disorders not elsewhere classified. And as this name suggests, this is a rather heterogeneous grouping of disorders that arguably didn't fit well within the current classification system. It includes pathological gambling, kleptomania, pyromania, intermittent explosive disorder, which is problems with aggressive behaviors and acting impulsively in an aggressive fashion. Trichotillomania, which is repetitive or interfering patterns of hair pulling, as well as an impulse control disorder not otherwise specified category that currently could be used to diagnose compulsive buying or compulsive shopping, non-paraphilic sexual behaviors, compulsive sexual behaviors, problematic internet use or compulsive computer use, as well as perhaps a variety of other conditions. From a clinical perspective, I would argue that these disorders often go unrecognized and untreated and may lead to prolonged hospitalizations as well as prolonged suffering on the parts of patients. Some of the data that suggest that these disorders go unrecognized in clinical settings come from a couple of studies that John Grant spearheaded. One was a study of 204 consecutive inpatient admissions to an adult psychiatric hospital where they were screened for a current impulse control disorder, and if they screened positive, a follow-up diagnostic interview was performed. And that study found that slightly over 30% had a current impulse control disorder, and this contrasted to the less than 2% that had been given a diagnosis of an impulse control disorder upon admission. A similar study looking at adolescents found that about 40% screened positive with follow-up confirmatory diagnostic interview, and this contrasted to the about 1% of individuals who had been given a diagnosis upon admission. So specifically, these are data from the adult study. These are the frequencies of the individual impulse control disorders. The most frequently identified was compulsive buying, which was at about 10% of the sample. Trichotillomania was the least frequently identified at 3 to 4% of the sample. And pathological gambling was identified in about 7% of individuals. And this is significantly higher than in the general adult population, where prevalence estimates typically range in about the 0.5 to 1% range. Of note, the past year estimates frequently approximated or were equal to the lifetime estimates, suggesting that these were active problems for people. When we looked at some of the identifying differences between individuals with and without impulse control disorders, we looked at whether there were differences in admission diagnoses, and there were no differences for mood, psychotic, or substance use disorders, suggesting that these disorders are comorbid with a broad range of psychiatric conditions. Consistent with this notion, the adults with an impulse control disorder were more likely at a trend level to have multiple non-impulse control disorder diagnoses, so they were more likely to have frequent comorbidities, more than one axis 1 disorder. So this highlights the importance of assessing for co-occurring disorders, as was mentioned in the introduction. Amongst the adolescent sample, the presence of an impulse control disorder was associated with internalizing disorders like mood or anxiety disorders. There were high levels of externalizing disorders like substance use disorders, conduct disorders, in both the groups with and without impulse control disorders. And the most robust finding from a statistical standpoint was with prior hospitalization, where the group with impulse control disorders were more likely to have been hospitalized previously, suggesting that this is either a more severely ill group of individuals, or perhaps that not targeting the impulse control disorder in treatment might lead to recurrent hospitalizations. The adolescents, as compared to the adults, had a different pattern of impulse control disorders, with intermittent explosive disorder being the most frequently identified. And that's shown here for the overall adolescent sample, broken down by gender. We found that there was not a statistically significant difference between the boys and the girls with respect to the frequencies of the impulse control disorders overall. We did, however, to our surprise, find that pyromania and compulsive sexual behaviors were more frequently identified in the girls as compared with the boys, and the extent to which this reflects the nature of the sample adolescents who are being hospitalized for mental health care versus what is found in the community, I think warrants additional study. So data from the community find that problem pathological gambling, as well as subsyndromal levels of gambling, those that do not meet the diagnostic criteria for pathological gambling, there are high rates of co-occurrence with a broad range of psychiatric disorders. So these are data from the St. Louis site of the epidemiological catchment area study, and what are shown are odds ratios with 95% confidence intervals. So numbers greater than 1 reflect higher odds of having a co-occurring disorder in the problem pathological gambling versus non-gambling groups, and then the recreational gambling versus non-gambling groups. And one can see that these stars indicate a statistically significant elevated ratio. And for a broad range of disorders, internalizing disorders like major depression, dysthymia, externalizing disorders like substance use, behaviors and disorders, and antisocial personality disorder, as well as psychotic disorders like schizophrenia, there are elevated odds for these disorders and behaviors within the more severe gambling group. So for a good part of the talk, I'm going to focus specifically on the relationship between pathological gambling and substance use behaviors and disorders. And there are data to suggest that there are similarities across a number of domains, high rates of co-occurrence, both in population and clinical samples. There are similarities in the clinical courses of the disorders with high rates in adolescents and younger adults, lower rates in older adults. A telescoping phenomenon that was initially described for alcohol use and alcoholism, later for drug use and drug use disorders, appears applicable to gambling behaviors as well. Specifically, this telescoping phenomenon is that women, as compared with men, tend to initiate engagement in the behavior at a later point in life, but the time frame between the onset of engagement and the development of a problem with the behavior is foreshortened or telescoped in women. There are also similarities in the clinical characteristics. Some of these are reflected in the diagnostic criteria for pathological gambling and drug dependence, and these include aspects of tolerance, withdrawal, repeated attempts to cut back or quit, and interference in major areas of life functioning. Some of the important elements, or what we think are important, are not currently reflected in the diagnostic criteria, and these include appetitive urge or craving states that may immediately precede the engagement in the addictive behavior. And then there are also similarities in the underlying biologies, both with respect to genetic contributions and neural contributions, and I'll talk more about those later. And some of that similarity might be reflected in treatments. And as there are similar treatments that appear to have efficacy for substance use disorders and problem pathological gambling. These include self-help approaches like Alcoholics Anonymous and Gamblers Anonymous, behavioral therapies like cognitive behavioral therapy and motivational interviewing and motivational enhancement, as well as brief targeted interventions. And then pharmacotherapies like opioid antagonists like naltrexone and nalmefene. So in thinking about the relationship between pathological gambling and substance use disorders, there may be some common elements that link the two. And these are a few Yu-Gi-Oh cards that I scanned in from my son's Yu-Gi-Oh card collection when collecting these cards occupied a large part of his motivational behavioral repertoire. And on the left, we have Mr. Volcano, who's a seemingly mild-mannered creature who has an extremely volatile temper. And he might be the type of person who rushes recklessly into certain behaviors or might be considered impulsive by nature. And so one of the thoughts that we had was that perhaps there are these features like impulsivity that might warrant investigation as intermediary phenotypes that might link the co-occurrence between pathological gambling and substance use disorders. With this in mind, we looked at some definitions for impulsivity, and one that was forwarded by Jerry Muller and colleagues now about a decade ago was a predisposition toward rapid, unplanned reactions to internal or external stimuli with diminished regard to the negative consequences of these reactions to the impulsive individual or to others. With this in mind, I think there are several important features. One is that there are shared elements between the core features of addiction and this definition for impulsivity. For example, the diminished regard to the negative consequences that Howard Schaefer and others have described. Second is that impulsivity is relevant to multiple psychiatric groups, including individuals with impulse control disorders and substance use disorders, but not limited to those groups, and might explain a broader range of co-occurrence between pathological gambling and psychiatric conditions. And then third is that impulsivity fractionates into multiple components. When people have done factor analyses of impulsivity-related measures, they typically identify two or more factors. Two that are repeatedly identified may be termed choice and response impulsivity, and having both self-report and behavioral measures of these constructs we think will be important in terms of mapping them onto clinical conditions and their treatment. And then another area that we've been interested in, and I think the field has been moving towards, is thinking about how during the addiction process behavior might change, and it might move from being arguably more impulsive to being more compulsive or habitual in nature. And in the way that impulsivity has been defined and characterized over the past decade, we think that compulsivity as related to pathological gambling, addictions, as well as other psychiatric disorders will warrant similar attention. So one way in which motivational systems in which addiction has been conceptualized over the past several decades has arguably been related to pro-motivational drive and control systems, self-control systems. And several circuits, such as the mesolimbic dopamine system, have been widely implicated in addictive behaviors. And frontal cortical systems, including involving both serotonergic, dopaminergic, as well as other neurotransmitter function, appear important in this process. With this in mind, we proposed a simplified motivational neurocircuitry diagram now going back 8 years. And in this diagram, what we proposed as a central component is highlighted by this golden arrow. And this golden arrow represents corticostriatal thalamocortical circuits that Alexander and colleagues, amongst others, have described now going back 20 years or so. And these parallel circuits that course from the cortex through striatum, thalamus, and other brain regions, those that course through the more ventral components have been hypothesized to be particularly relevant to reward processing, to reward-based learning, to perhaps impulsive behaviors, whereas those that course through the more dorsal components of cortex and striatum appear particularly relevant to habitual and perhaps compulsive behaviors. Parsed out in blue, we hypothesized that a series of secondary motivational neurocircuits would be relevant, with the amygdala and related brain regions providing important affective information into the circuitry, the hippocampus and related brain regions providing important contextual memory information. What have I done in similar circumstances in the past, for example? And the hypothalamus and septum and related brain regions providing important homeostatic information relating to sex drive, thirst, hunger, that might influence decision-making processes and motivated behaviors. So with this in mind, we were using this as a framework for testing hypotheses and superimposing upon that roles for specific neurotransmitters, as data suggested that, for example, norepinephrine systems are particularly relevant to arousal and excitement, serotonin systems particularly relevant to behavioral initiation and cessation or impulse control, dopamine systems particularly relevant to reward and reinforcement, and opioid systems to pleasure and urges. Understanding that these are oversimplifications and that the brain functions more at a neurocircuitry level involving an interplay of these neural circuits and neurotransmitter systems. With that in mind, we thought that this was an important starting point and focused some initial work on serotonin systems. There's been a long history of serotonergic involvement in impulse control. Lanoila and colleagues, going back now 4 decades or so, have implicated serotonin systems through studies of cerebrospinal fluid samples and serotonin metabolites, finding differences in individuals with impulse control problems, such as those with alcoholism, those with pathological gambling, those with pyromania. And Eric Hollander and his group extended this work by, in individuals with pathological gambling, looking at responses to serotonergic drugs, and finding that individuals with pathological gambling as compared to control subjects showed differences in response to drugs like MCPP, which is a serotonin 1 and serotonin 2 partial agonist, were differences in prolactin response at a biochemical level, and then at a behavioral level, finding that individuals with impulse control problems tended to report more of a high or a buzz in response to the drug as compared to control subjects who tended to report a more aversive or dysphoric response. Taking that work a step further, one of his colleagues, Larry Seaver and others, looked at MCPP and fenfluramine responses under brain imaging conditions, finding that individuals with impulsive aggression showed relatively blunted ventromedial prefrontal cortical activation in response to these pro-serotonergic drugs. With that in mind, when we initiated some of our brain imaging work in individuals with pathological gambling, we hypothesized that the ventromedial prefrontal cortex would show differences in individuals with pathological gambling as compared to those without. And our studies, as well as those from other groups, have demonstrated this across a range of neurocognitive paradigms under fMRI conditions. So, for example, during the Stroop color word interference task, during exposure to gambling-related videotapes, during reward processing, during simulated gambling, and during performance of a decision-making task, the Iowa gambling task, individuals with pathological gambling, or in this case, individuals with substance use disorders and pathological gambling, showed relatively diminished activation of the ventromedial prefrontal cortex. If we think that this might be related to serotonin systems, then perhaps drugs that influence the serotonin system might be helpful for changing behaviors in individuals with pathological gambling. And initial randomized clinical trials of serotonin reuptake inhibitors reported some positive results. These are data looking at the serotonin reuptake inhibitor paroxetine, looking at measures of clinical status where a lower measure represents better treatment outcome. And in this case, active drug versus placebo drug was distinguished in the week 5 to week 8 period during this trial of paroxetine, where paroxetine was superior to placebo in the treatment of individuals with pathological gambling. However, the first multi-center trial of paroxetine did not see a difference between active and placebo response. Here, a higher level on the bar graph represents better treatment outcome, looking at percentage of patients who were responders. What we found was that at the end of the 4-month trial, that individuals treated with active drug, 59% of individuals were responders as compared to about 50%, a little less than 50% of those treated with placebo. So the good news was that people in the randomized clinical trial were getting better. The perhaps more disappointing news was that we didn't understand exactly why they were getting better, as the difference between active drug and placebo drug was not statistically significantly different. However, we hypothesized that perhaps this may be due to individual differences, and perhaps those individuals who are more prone to internalizing disorders like anxiety or depression might respond better to a serotonin reuptake inhibitor. With that in mind, we performed a trial of escitalopram, which is another serotonin reuptake inhibitor, in individuals with co-occurring pathological gambling and anxiety disorders. And this was an open label trial followed by double-blind discontinuation. And what's shown here is the open label phase, looking at problem gambling severity and anxiety severity over time. And one sees a largely parallel decrease in both problem gambling and anxiety measures. What's not shown here is that randomization to active drug tended to lead to persisting improvement in both domains, whereas randomization to placebo was associated with resumption of symptoms in both the gambling and anxiety domains. So preliminary data, but encouraging. So another way of thinking about how to approach treatment we thought might involve focusing on choice impulsivity and thinking about risk-reward decision-making processes as individuals with pathological gambling and those with substance use disorders tend to perform disadvantageously on decision-making tasks like the Iowa gambling task. And individuals with ventromedial prefrontal cortical lesions also perform disadvantageously on this task, so it brings together some of our neurobiological findings. Also, from a clinical perspective, individuals who perform disadvantageously on the task, such as drug-dependent individuals, the performance on the task correlates with real-life measures of functioning, like the ability to hold a job. We've also found that some measures of choice impulsivity, in this case a temporal discounting or delayed discounting measure, behavioral measure of choice impulsivity, is related to treatment outcome for individuals with addictions. So here it's shown that in adolescents seeking to quit smoking, those who were abstinent at study end versus those who were non-abstinent, those who were able to maintain abstinence at treatment onset had less shallow discounting curves. So they did not place as great a value on immediate versus long-term rewards as we had discussed earlier. So this raises questions as to what's going on in people's minds when they select smaller immediate versus larger delayed rewards. And Jonathan Cohen's group at Princeton found that the selection of small immediate rewards was associated with activation within the ventral striatum and the ventral medial prefrontal cortex, whereas the selection of larger delayed rewards tended to recruit more dorsal cortical brain regions. And with this in mind, thinking about the selection of small immediate rewards, one can think about what is going on with respect to reward processing during the receipt of small immediate rewards. So we've taken Brian Knutson and Daniel Hammer's monetary incentive delay task and modified it to look at different aspects of reward anticipation. What they found in some of their initial studies was that reward anticipation anticipation of working for monetary reward was associated with ventral striatal activation, whereas the consummatory or receipt phase of reward processing was associated with ventral medial prefrontal cortical activation. These studies were initially performed in individuals without addiction, raising the question as to what is happening at a neural level in individuals with addiction. Studies from the Hammer group as well as the race group in Germany found that individuals with alcohol dependence tend to show relatively diminished ventral striatal activation during the reward anticipation phase, and that this relatively diminished activation of the ventral striatum appeared to extend to individuals who may be considered at risk for addiction. Furthermore, some of their recent work, as well as some of ours, relates this to impulsivity, in that in both alcohol dependence and in pathological gambling, this relatively diminished activation of the ventral striatum during reward anticipation appears linked to measures of impulsivity, so that the less the ventral striatum activates, the more impulsive individuals are by self-report measures. And this relatively diminished activation of the ventral striatum appears to relate to pathological gambling in a broader sense. So in several studies, some that we have performed, some that Reuter et al. Reported from Germany, we see relatively diminished activation in individuals with pathological gambling versus control subjects when viewing gambling tapes, in a similar fashion that individuals with cocaine dependence versus control subjects viewing cocaine tapes show relatively diminished activation in the ventral striatum and the orbital frontal cortex. We see this during reward anticipation in individuals with pathological gambling versus control subjects, as shown here. And then Reuter et al. Found this during simulated gambling, and what they also found was that the degree of ventral striatal activation correlated inversely with problem gambling severity. So the less that the ventral striatum activated during simulated gambling, the more severe the gambling problem. So I think these findings of ventral medial prefrontal cortical differences and ventral striatal differences, or less activation within these brain regions being associated with pathological gambling, appears consistent across a range of studies. They also appear to extend to the impulse control disorder literature in individuals with Parkinson's disease. So here, individuals with Parkinson's disease and impulse control disorders as compared to those without impulse control disorders and with Parkinson's disease during performance of a risk-taking task. The group with the impulse control disorder show relatively diminished activation of the ventral striatum. There's a possibility that this may be linked to dopaminergic function, although this has not been tested specifically. But a group in Toronto has found ventral striatal differences in dopamine function, both at baseline and during simulated gambling or during a gambling task. And this pattern is similar to one seen in individuals with Parkinson's disease and dopamine dysregulation syndrome, where the individuals excessively take their dopamine replacement therapies. And again, the ventral striatum, but not the dorsal striatum, is implicated with respect to dopaminergic differences. However, just because the findings link to the ventral striatum does not necessarily mean that they are related to dopamine dysfunction. We have been investigating serotonin function within the ventral striatum, specifically looking at the serotonin 1B receptor. And what we found in individuals with alcohol dependence is that they show they show increased binding of a serotonin 1B selective ligand. In individuals with pathological gambling, we did not observe a between-group difference, but we did, within the individuals with pathological gambling, observe a correlation between the binding potential and problem gambling severity. So in both cases, increased binding of the serotonin 1B receptor ligand was associated either with increased severity of the disorder or with the disorder itself. The similarities between pathological gambling and alcohol dependence may extend to other areas as well. These are DTI, or diffusion tensor imaging findings, where individuals with pathological gambling show poorer white matter integrity within the corpus callosum, and specifically within the genual component of the corpus callosum. And these findings are similar to other substance use disorders, particularly alcoholism, in which poorer white matter integrity has been implicated more diffusely. And these findings of between group differences are in part accounted for by co-occurring lifetime alcohol abuse and dependence, but not fully accounted for, suggesting that there may be components from both disorders contributing to the white matter integrity finding. And that brings us to the relationship between alcohol use and gambling. This is a precursor to a scratch-off lottery ticket. So this is an actual piece of gambling paraphernalia that I scanned in. And in this case, one would pay 10 cents, and each one of these beer steins that you would push out for the 10 cents would have a number on the back, and you would either receive 1 beer or 2 beers, highlighting the complex relationship between gambling and alcohol use at a social level. From a biological level, there are data to suggest that there are shared genetic contributions to the co-occurrence of alcohol dependence and pathological gambling. And if we think about this from a treatment development perspective, it suggests that perhaps some drugs that are effective for the treatment of alcohol dependence might be helpful for the treatment of pathological gambling. And of those that are approved and appear efficacious, we thought that the opioid antagonists like naltrexone might be particularly attractive given their proposed mechanism of action of influencing indirectly dopaminergic neurotransmission within the mesolimbic pathway from the ventral tegmental area to the nucleus accumbens. So to date, there have been 4 randomized clinical trials that have found either naltrexone or nalmefene to be superior to placebo in the treatment of pathological gambling. Furthermore, it's not that simple that one can give everyone naltrexone and expect everyone to do well. There are a significant number of people who do not appear to respond well to naltrexone, raising the question that there might be important individual differences. So we looked for clinical factors that were associated with a treatment outcome to either naltrexone or nalmefene. And what we found was that the most statistically robust finding for the whole sample was a family history of alcoholism, suggesting that perhaps those individuals who may be at risk for alcoholism might be the ones who respond particularly well to opioid antagonist treatment. We also found that gambling urges at treatment onset were associated with treatment outcome, particularly amongst individuals who were receiving higher doses of the opioid antagonist. We found a different pattern amongst individuals receiving placebo. In this case, we found that age was most strongly associated with treatment response, where older individuals were less likely to respond to placebo. And this suggested to us that this pattern, this association with a family history of alcoholism was more specific to the active drug treatment condition. So this is a postcard. I'm not sure if this casino is any longer in business, but it's meant to highlight the relationship between gambling and mood symptomatology. And there are data to suggest that at a biological level, there might be some relationship. So I mentioned earlier that individuals with pathological gambling as compared to control subjects show this difference in ventromedial prefrontal cortical activation during the Stroop color word interference task, relating to the individuals with pathological gambling showing greater deactivation of the ventromedial prefrontal cortex than control subjects do. Hilary Blumberg at our institution performed a similar study investigating individuals with bipolar disorder, and she found identified a largely similar brain region as distinguishing most the individuals with bipolar disorder from control subjects, suggesting that there may be similar neural correlates between the disorders. Some of this may translate to treatment. So work from Eric Hollander's group in individuals with pathological gambling and co-occurring bipolar spectrum disorder, largely bipolar 2, found that active lithium was superior to placebo in a randomized clinical trial where the active drug was statistically significantly different, both in a reduction of problem gambling severity as well as in a reduction of mania measures. However, pathological gambling, as we heard during the introduction, also co-occurs with major depression. And we set to try to understand this relationship better by looking at the Vietnam-era twin registry sample, which is a large sample of male twins, over 7,000 individuals. What we found was that there was an unadjusted odds ratio for major depression and pathological gambling of 4.1. This was largely similar for when we adjusted for sociodemographic differences. It dropped to 2 when we modeled in co-occurring or other psychiatric conditions. So these data suggest that some of the relationship between pathological gambling and major depression is accounted for by these other co-occurring disorders. However, a statistically significant relationship between pathological gambling and major depression existed when accounting for these disorders as well as for sociodemographic differences. One of the exciting things about twin data is that one can model the data to understand the genetic and environmental contributions to each disorder and their co-occurrence. So in this sample, the estimates for pathological gambling was that about 2/3 of the variance was attributable to genetic factors and about 1/3 to environmental factors. In comparison, major depression was about 40% genetic and 60% environmental in nature. But most interesting to us was in modeling the co-occurrence between the disorders. The best fitting model suggested that the overlap was due to shared genetic factors. In this model, entirely to shared genetic factors, but these models tend to overestimate the genetic contributions. However, it suggests that a substantial component of the relationship between pathological gambling and major depression may be found at a genetic level, and thus there may be some shared biological targets for prevention and treatment development. This appears particularly relevant to women. These are data from the National Epidemiological Survey of Alcohol and Related Conditions, where this is a survey of over 43,000 individuals in the United States. And what we found was that there was a gambling by gender interaction effect for major depression, in which with increasing problem gambling severity, there was a difference in the rates of major depression in the population, such that there was a stronger relationship between pathological gambling, problem pathological gambling, and major depression in women as compared with men. And this may relate to some of the differences in motivations that underlie gambling behaviors, where women are more likely to report gambling to escape from depressed mood, as compared to men who may be more excitement seeking. So with this in mind, we have generated a preliminary treatment algorithm for pharmacotherapies. As mentioned before, there are a number of behavioral therapies that appear effective for people. And we've based this on the presence of co-occurring conditions, where in the absence of co-occurring conditions, perhaps naltrexone or an opioid antagonist might be a first-line treatment. I did not discuss data on N-acetylcysteine, which is a nutraceutical or a product that one can buy in a health food store, but it appears to show in preliminary studies efficacy for both pathological gambling and for substance use disorders. And then perhaps if individuals have a co-occurring disorder, or perhaps even a family history of a co-occurring disorder or a disorder, that might be used to guide treatment selection such that individuals with bipolar disorder or bipolar spectrum disorder might receive benefit from a mood stabilizer like lithium. Individuals with a family history or personal history of substance abuse or dependence might, one might consider naltrexone, and perhaps with an affective disorder, consider a serotonin reuptake inhibitor, although the data for serotonin reuptake inhibitors, as I've described, are mixed. So I will quickly go through some impulsivity and individual differences data. We, as mentioned earlier, are interested in impulsivity, compulsivity, and other aspects of self-control as perhaps some intermediary phenotypes that might be clinically relevant for treatment targeting. Some data that we have in this domain is by incorporating self-report and behavioral measures of impulsivity and compulsivity into treatment trials. If we looked at self-reported impulsivity and compulsivity in the paroxetine trial, we found that at treatment onset, problem gambling severity measures correlated both with aspects of impulsivity and aspects of compulsivity, particularly impaired control over mental activities. We found that while both impulsivity and compulsivity measures decreased during treatment, the changes in problem gambling severity correlated most closely with changes in impulsivity rather than compulsivity. In a separate trial of memantine, which is a glutamatergic drug, we incorporated behavioral assessments related to impulsivity, such as the stop signal task, as well as those that are potentially related to compulsivity, like an interdimensional, extradimensional set shifting task, during which one can measure perseverative errors. And what we found was that at treatment onset, individuals with pathological gambling differed from those without, both on measures of compulsivity and impulsivity. And following treatment, the individuals with pathological gambling did not differ from control subjects on these measures and showed statistically significant changes from baseline on measures of compulsivity as assessed by perseverative errors on the interdimensional, extradimensional set shifting task. So we think that thinking about impulsivity and compulsivity as it relates to treatment of pathological gambling will be perhaps one other new way of approaching matching individuals with specific treatments. And I think I'm running out of time. One other area that we've been focusing in on is to think about the neurobiology of behavioral and pharmacological treatments for addictions, both pathological gambling as well as substance addictions. Some of this work has been done in conjunction with our Psychotherapy Development Center, where we incorporate brain imaging measures into trials of behavioral therapies for drug addiction. We hope to be doing something similar over time in individuals with pathological gambling. What we found, for example, during performance of the monetary incentive delay task is that in contrast to alcohol dependence and pathological gambling, cocaine-dependent individuals appeared to show overactivation of reward circuitry on the monetary incentive delay task. And this increased activation is related to poorer treatment outcome. In contrast, at pre-treatment, when they perform a cognitive control task, the Stroop, relatively increased activation of similar brain regions like the striatum and the ventral medial prefrontal cortex is associated with better treatment outcome, suggesting that perhaps there are differences with respect to bottom-up processes like reward processing versus top-down processes like cognitive control with respect to the neural circuits that are recruited and their relationship to treatment outcome. We've been trying to take this a step further by using advanced image analysis techniques like independent component analysis to move beyond looking at specific brain regions, but instead look at brain circuits and their relationship to task performance, to group differences, and to aspects of treatment outcome. And in this case, we identified 6 independent components, so functionally integrated activations, that show differences that relate to the Stroop color word interference task performance of incongruent versus congruent stimulus presentation, with specific circuits, this singular opercular and singular motor, which might be involved in linking regions like the insula to the anterior cingulate and anterior cingulate to motor regions, are showing between group differences. This circuit, this medial cingulofrontal circuit, which relates dorsolateral prefrontal cortical activations to anterior cingulate activations, appears particularly relevant to treatment retention, whereas those circuits that involve subcortical regions and ventral prefrontal regions appear particularly relevant to abstinence-based measures of treatment outcome. So it suggests that there are specific neural circuits that might represent independent targets for treatment development for addictions. Another area that we think is exciting is to think about other targets, perhaps white matter and changes in white matter integrity as a potential target for treatment outcome. And some of our data in cocaine-dependent individuals associates different aspects of white matter integrity to different aspects of treatment outcome, particularly to self-reported and urine toxicology-based abstinence. And taking this approach to pathological gambling, we think could be informative. So, in summary, there exist multiple shared features between pathological gambling and substance use disorders, as well as other disorders characterized by impaired impulse control. We believe that more research should help define the precise biological etiologies of both similarities and differences between the disorders, and investigate clinically relevant individual differences, such as those related to impulsivity, compulsivity, gender, amongst others. And that taking this information to the next level would involve translating this into improved prevention and treatment strategies, and taking those strategies out into the community so that we can help a greater number of people. So I'd like to thank a broad range of individuals as well as funding agencies for this work. So thank you.